Hello, and welcome to our program titled Ushering in a New Era in the Treatment of Chronic Kidney Disease and Anemia, Appreciating the Patient Burden, Exploring Pathways and Pathogenesis, Reflecting on New and Emerging Data. I'm Dr. Ajay Singh, Senior Associate Dean for Postgraduate Medical Education and Director of the Master's in Medical Science in Clinical Investigation Program at Harvard Medical School. I'm also a nephrologist at the Brigham and Women's Hospital here in Boston. I am joined today by my esteemed colleagues, Dr. Edgar Lerma, who's Clinical Professor of Medicine from the University of Illinois in Chicago, Illinois, and Dr. Jay Wish, Professor of Clinical Medicine at the Indiana School of Medicine. Dr. Wish serves as Chief Medical Officer for Outpatient Dialysis at Indiana University Health in Indianapolis, Indiana. Our faculty disclosure is displayed on the screen for your convenience. This program is supported by an educational grant from GSK. We would like to thank them for support for this initiative. Our program today will include a robust presentation and panel discussion surrounding the prevalence and burden of anemia and CKD. The learning objectives for this initiative is as follows. Summarize the prevalence and burden associated with anemia in patients with CKD. I'll now turn the presentation over to Dr. Edgar Lerma, who will lead us through a brief presentation on the prevalence and burden associated with anemia in patients with CKD. At the end of the didactic portion of the presentation, Dr. Wish and I will join Dr. Lerma for an interactive panel discussion.
Thank you very much, Dr. Singh. So for today, my topic is prevalence and burden of anemia in CKD. We know that CKD is a prevalent disease that affects a lot of Americans. In fact, more than 37 million Americans, or 1 in 7 people have CKD. Of those patients with CKD, 5 to 6 million people actually have anemia. In this study, they looked at severe anemia, defined as hemoglobin less than 10 grams per deciliter. It is demonstrated that as CKD progresses from lower stages to more advanced stages, there is actually a correlative increase in the prevalence of anemia. There's a significant disparity in the way anemia is seen among different populations. In fact, here you could see the prevalence of anemia in non-Hispanic Blacks as compared to other races. This is another depiction of that disparity. This is a retrospective longitudinal study of 22,000 patients with CKD with and without anemia. And as you can see in this slide, they looked at the outcomes per 100 patient years, and looking at the outcomes of hospitalization for heart failure, advancing CKD, as well as 40% decline in GFR, you can see there's a significant difference between patients who have anemia as compared to those without. Now, if you look at the right side of the slide, you could see that these patients have the highest hematocrit, while on the leftmost of the slide, you have the lowest hematocrit. And it is shown in this slide that the higher the hematocrit is, the lower the mortality is seen. And this is in patients on dialysis. Now, let's also look at the burden of anemia in CKD. We know that CKD is a multiplier. The two most common causes of CKD in the US are diabetes and hypertension. Patients can also have high cholesterol, thyroid problems, depression, heart disease, chronic respiratory diseases, gout, electrolyte abnormalities such as hyperkalemia. And if you look at the right side, if we consider the quality of life of these patients with anemia as compared to those without, you can see that there's significant activity and work impairment in those with anemia. Let's look at other people surrounding the afflicted patients. And here we're looking at the caregivers. So it is apparent that in patients with CKD with anemia, their caregivers actually have problems as well. So on the right side, you can see they have more anxiety, depression, headaches or migraines, GI symptoms, as well as diabetes. And you could see on the left side, the purple depicts those with anemia. Severe burden is noted in a majority of these caregivers. Now, let's take a step back and see How do we manage whenever we see patients with anemia of CKD? When we diagnose these patients, the goal is to increase the hemoglobin. And how do we get to that? We may give ESAs or erythropoietin stimulating agents. We may sometimes give iron for patients with iron deficiency. And the goal of this is really to increase RBC production and then increase hemoglobin. As a last resort, blood transfusions are sometimes used. So we try to avoid blood transfusions for the most part. But regardless, all of these three factors, ESAs, supplemental iron, as well as blood transfusions, the ultimate goal is to increase the hemoglobin. So let's now look at the use of ESAs. We know that ESAs increase hemoglobin and improve anemia. There are two ESAs that are generally used. One is recombinant human erythropoietin, and the other one is darbepoetin, which has longer half-life, thereby requiring less frequent dosing. ESAs typically are considered when the hemoglobin is less than 10, and the target hemoglobin is 10 to 11 grams per deciliter. I will talk about why that is the target later on in the next few slides. But what we also know is that higher doses of ESAs lead to potential and certain risks of increased cardiovascular complications and mortality. Now, what about those patients with CKD who are not on dialysis and their anemia is left either not treated or undertreated? Well, what does this lead to? So, as you can see here, these patients have reduced quality of life, especially physical functioning. These patients require higher risk of blood transfusions, which I showed in the previous slide to be our last resort. And of course, the more blood transfusions, the higher the risk of infections. We also know that blood transfusions can sometimes be limited and is quite expensive. And if we look at patients who are transplant candidates, there's a higher risk of allosensitization in these patients. Now, if we consider the 9 million people with moderate to advanced CKD who are not on dialysis, only 12 to 17% are actually treated with ESAs. There are also challenges with the use of ESAs for treatment. Here, we are emphasizing the safety concerns. As I mentioned earlier, there are potential and certain risks of increased risks of cardiovascular events in patients who require higher doses. On the right side, you can see the table. These are the three studies: the normal hematocrit study, the CHOIR study, and the TREAT study. And they actually demonstrated this increased risk of cardiovascular events when higher doses are used. There's also the problem of increased burden to patients. So if they use short-acting ESAs, that is administered 3 times a week. On the other hand, long-acting ESAs have been associated with increased mortality as compared to short-acting ones. There's also the issue of cold storage requirements. So you cannot just keep your ESAs in a cabinet. Then there's also generation of anti-EPO antibodies, which has been described in literature. And then there's cost considerations. In 2019, it has been shown that the total excess ESA costs around $2.5 billion. That's a little over $5,000 per patient. And this is accounted for by, say, direct healthcare costs, lost work or productivity for the patient, and also the caregiver, or even transportation costs. And of course, another challenge with ESA treatment is ESA hyporesponsiveness. This is seen in approximately 7 to 10% of patients who are on dialysis. Now, there are differing definitions of ESA hyporesponsiveness, but in general, it is difficulty of reaching hemoglobin targets, which is 10 to 11, despite treatment with higher doses. Again, I keep emphasizing higher ESA doses are attendant with increased risk of adverse cardiovascular outcomes. Anemia and symptoms related to anemia remain despite treatment in these patients. Now, on the graph on the other side, I want to show you that anemia can lead to ESA hyporesponsiveness, for which our response is to increase the dose of the ESA. Now, what's important to emphasize in this slide is that there are associations with increased risk of mortality. So the higher the dose of ESA use, there's an association. And I have to emphasize this is an association because there's no proof of causality yet. So high ESA doses leads to increased risk of mortality. But not only that, anemia per se leads to increased risk of mortality. So ESA hyporesponsiveness also increases risk of mortality. And we know that chronic kidney disease is a state of inflammation, and that by itself also increases the risk of mortality. So the key takeaways from this presentation, 37 million Americans have CKD, and of those, 5 to 6 million have anemia. The prevalence of anemia increases with the stage of CKD. It is a significant burden to morbidity, mortality, as well as quality of life. The treatment for CKD anemia involves ESAs, iron supplementation, and as a last resort, blood transfusions. There are several unmet needs in CKD anemia treatment, and there are numerous challenges to use of ESA. As I mentioned earlier, the increased risk of cardiovascular events. And only 12 to 17% of people who should be on ESA are actually treated. Thank you.
Thank you very much, Dr. Lerma. That was a very concise and eloquent description about the prevalence and some risk factors for anemia in patients with CKD. We're going to just take a few minutes to do a panel discussion, and I'm inviting back Dr. Jay Wish and, of course, Dr. Lerma to join. Let me ask the first question. Dr. Lerma, you presented data on the disparity of levels of anemia in the US. It seems like the proportion of African Americans with anemia is becoming progressively worse. How do you explain this?
You know, when I look at these studies, the way I looked at it, you know, I was asking myself, what is driving this? And the automatic answer is could the socioeconomic costs be part of this? And then the other factor that can explain this probably are the medical conditions like vascular disease, diabetes. We know CKD per se disproportionately affects African Americans and all the attendant diseases. I remember there's a paper by Dr. Cushman published in, I believe, 2009, wherein they were trying to see, you know, what factors were associated with this difference between blacks and whites. And I think they ended up saying the socioeconomic factors and medical conditions, but these are modifiable.
Great. Let me ask you this, Dr. Wish. Do you have anything to add to that? I mean, do you think that socioeconomic factors and access to ESAs explain this, or do you think it's some people have speculated that it may be because of poverty, African Americans are not exposed to food that is rich in iron, and that they're more iron deficient? Any thoughts on that?
Well, I think it's all of the above. I think there are clearly nutritional challenges among socioeconomically disadvantaged patients who are more highly represented among minorities such as Blacks and Hispanics. I think there also may be an effect of denominator. What may be occurring is that there's actually increased diagnosis of chronic kidney disease among disadvantaged populations because of efforts by national organizations such as the National Kidney Foundation to do screening. And as the denominator go up, but these challenges remain, the proportion of patients who are actually getting effective therapy is going down.
Great. Dr. Lerma, maybe you could give us a short explanation of why you think there's a higher risk of cardiovascular disease among patients with CKD anemia. Do you think this is a real risk, or this is one of those associations that we see in these observational studies of patients who are anemic with CKD?
You know, I think the way I looked at it when I was looking at the CHOIR study, the TREAT study, you know, what we know is that giving them ESAs increases the RBCs, and I think this is a correlation wherein you increase the RBCs, you increase the volume of RBCs, then there's likely higher risk of thrombosis or thrombotic events like cardiovascular diseases. I think that is the primary driving factor in this.
It's interesting. I remember a study many years ago by a good friend and an old colleague of ours, Dr. Collins from Hennepin, who published work on CKD anemia being the anemia part of it being a risk multiplier for bad cardiovascular outcomes. Dr. Wish, any thoughts about that?
Well, I think what we're seeing here is not necessarily cause and effect because it doesn't adhere to Koch's postulates. And Koch basically said that if you have a pathogen for an infectious disease, you eradicate the pathogen and the infection goes away, and then you re-challenge and the infection comes back. I think what we have, as Edgar said, is an association. To establish causality, it would be nice to have demonstrated among these randomized controlled trials, such as Choir and the normal hematocrit study, that improvement of the anemia actually decreased the cardiovascular events. And in fact, the opposite was true. So I think what you have is inflammation. And as we mentioned, inflammation is pretty much pandemic among patients with chronic kidney disease. The inflammation is probably adversely affecting red cell production, but it's also causing cardiovascular risk.
We've now reached the end of our allotted time for today. I'd like to thank my colleagues, Dr. Lerma and Dr. Wish, for a great presentation and lively discussion surrounding the prevalence and burden of anemia in CKD. Also, we would like to thank GSK for their support of this program. We would like to ask the learners to please follow the link that is provided at the end of the program and in the thread below to fill out this evaluation and post-test in order to receive CME credit. This provides us with valuable feedback that will be used for the planning of upcoming programs. This is part one of a 4-part series. There will be 3 additional social media broadcasts scheduled for September 21st, September 28th, and October 5th, 2022 at 2:30 p.m. Eastern Daylight Time. Join us as we explore the pathogenesis of CKD anemia and new pathways, emerging agents targeting HIF, and patient-centered care in the new era. Please follow the Iridium CE social media Twitter or Facebook page so you will be sure not to miss updates. Thank you for joining us.